Hello, I'm excited to be giving this talk today as part of UVA's prostate education series and as part of prostate cancer awareness. I'm Dr. Chris Luminais. I'm an assistant professor in UVA's Department of Radiation Oncology. Today I'm going to be focusing on treatment options for prostate cancer. This talk is being done jointly with my close colleague, Dr. Kirsten Greene. She's one of our urologic surgeons. I will be focusing on the radiation aspects of treatment. Dr. Greene will be talking about surgical aspects and active surveillance options. We're doing this in tandem because for most prostate cancer patients, we have options. Most patients with localized prostate cancers will have equally good outcomes with both surgery and radiation. And because we get equally good cure rates and equally good outcomes, we usually want to take a multidisciplinary approach and have a patient see both teams to learn about both their surgical options and the radiation options. I think of this as an opportunity to figure out which option is the best fit for each patient as an individual. So I'm going to start by talking about staging and risk categories for prostate cancer. And then I'm going to walk through the various types of radiation and some additional treatments that we do in conjunction with radiation. And the other parts will be covered by Dr. Greene. The first part is staging and risk grouping. We always look to the National Comprehensive Cancer Network for things like this. And they have a very detailed staging and risk categorization system that helps us determine the prognosis and the treatment options for each individual. The risk grouping is primarily based on a number of tests, the PSA level, the Gleason score, and the results of an examination in an MRI. So I know another one of my colleagues, Dr. Tracy Downs, already gave a separate video about prostate cancer early detection, evaluation, and diagnostic workup. So he probably covered these in more detail than I will here. But for this lecture, I'm going to cover what these are and how they contribute to a risk categorization. The PSA blood test is the first one. That is a protein that is produced by the prostate. Prostate cancers tend to release more of this protein into the bloodstream. So if we detect this, that's often the first step of us becoming aware that you may have a prostate cancer that needs further evaluation. Higher PSA levels are typically associated with higher risk cancers. The next piece of information is the Gleason score. So a Gleason score comes from a prostate biopsy, and what it does is describes how abnormal the cancer cell looks. So if you look at this diagram here, in green are sort of normal non-malignant cancer cells. In yellow in the middle are Gleason category 3 low-grade prostate cancer cells that look abnormal but still look somewhat similar to normal prostate cells. And then Gleason 4s and 5s are more disordered and more aggressive appearing prostate cancer cells. When we do a Gleason score, the pathologist who's looking at the specimen under a microscope will give a first number, which is what we see the most of, and then a second number, which is the secondary pattern. And then we add them up to be a Gleason 3 plus 3 equals 6 for low grade, or a Gleason 3 plus 4 equals 7, and so on for the various Gleason scores. The general idea here is that higher grade cancers are more aggressive and have a higher risk of spreading or metastasizing to other parts of the body. The last major piece of information is findings from physical exam and imaging, usually an MRI, and then sometimes additional imaging like CTs or PET scans. But on any of these evaluations, we may see that there's a presence of a tumor nodule or tumor extending through the prostate capsule or into the adjacent seminal vesicles, which are other risk features we look for. So we then put that all together to make 3 overarching risk categories: low risk, intermediate risk, and high risk. So if you're being evaluated for prostate cancer, this is something that your doctor will go through with you in detail. But in broad categories, low risks cancers are Gleason 6s with PSAs less than 10, and no adverse findings on an MRI or a physical examination. Intermediate risk prostate cancers usually have Gleason scores of 7 or a PSA in the range of 10 to 20. And high risk is usually Gleason 8 or higher. and PSA scores 20 or higher. You can see on the right, there's a whole table that breaks these down even further into very low versus low, and favorable intermediate versus unfavorable intermediate, and high versus very high. So there's a lot of information here. I don't want to go through every point of it, but these are the things that your doctor will be looking at and going through with you when they're evaluating what category your prostate cancer is. So when we're treating a prostate cancer, we have a lot of different options. So active surveillance and surgery, which Dr. Greene will be talking about, the radiation options, the hormone therapy options. And the question we have to answer is, which treatments should we use for which patient? The overall strategy with the different low, intermediate, and high risk groups is that we tailor the treatment to match the risk of the individual cancer. So low risk and more favorable intermediate risk cancers might get surveillance, or if they get treated, it might be just a single type of treatment with just radiation or just surgery. High risk or more unfavorable intermediate risk cancers are more likely to get escalated therapy. We wouldn't usually do surveillance for those patients. If we did do radiation, we would often escalate it with hormone therapy. And for high-risk patients, if they do have surgery, we would know going into it that there would be a significant risk that after surgery, they might still need to get radiation and hormone therapy. So these distinctions are important because depending on your risk category, you might have a very different list of options compared to another patient who also has a prostate cancer. So I'm now going to jump into the specifics of the main forms of radiation we use. So there's 3 overall types of radiation, the first of which is called intensity modulated radiation, or IMRT. Before digging into this, I'd like to take a moment to just talk about what radiation is and how it works. So most patients are at least a little bit familiar with radiation because they've had scans like X-rays or CT scans. So those are scans that are taken with radiation beams. For diagnostic imaging, what we use is very low energy beams that shine through the body, expose digital film, and take the images that we use for X-rays and CT scans and things like that. With radiation therapy, it's a similar idea in that we're using an X-ray beam, but it's different because we're using a much, much higher energy X-ray beam. So we're not using a broad beam that goes through the whole body. Instead, we use a very pinpoint beam that focuses on just the areas we want to treat, and we deliver energy with a high intensity of ionizing radiation. We're able to do this because cancer cells are more easy to damage with radiation than normal cells. Normal cells are able to repair radiation better than cancer cells are. So what we see here is a typical treatment machine for a radiation treatment where a patient lays on the table, and then this machine here will rotate around and deliver the radiation beams to the appropriate areas. So IMRT is the most commonly used form of radiation. It typically entails doing daily radiation treatments with a small dose given every day. A typical treatment course that we would use here at UVA would be 28 days of radiation delivered over about 6 weeks, treating Monday through Friday. With this regimen, we can treat the prostate to a high dose. And for higher risk individuals who need it, we also have the option to do pelvic lymph node radiation. The lymph nodes are often the first area of spread. So if we've detected spread there, we'll treat the lymph nodes. Or in individuals who have high-risk features, even if the lymph nodes don't look like they have cancer in it or in them, we might still include preventative lymph node radiation to try and clear out microscopic spread in those areas. So this regimen takes about 20 to 30 minutes to deliver each day. And it's pretty well tolerated overall, but there are side effects. So with any of the treatment options we talk about, we're always focused on what the side effects look like, how well can it be tolerated, and how can we reduce those side effects. So short-term side effects are the ones that happen during radiation and for the first few weeks afterwards. This is typically things like fatigue, loose stools, and then the biggest one is urinary symptoms. The bladder and the urethra are in very close proximity to the area we're treating, so we do get some impact on urinary function with a lot of urinary frequency and urgency and weak stream. During a course of IMRT radiation, you would typically see your radiation oncologist at least once a week, and we would use a number of different medications and techniques to try and treat these symptoms and make the overall course pretty well tolerated. Most of these symptoms will recover within the first 1 to 3 months after a course of radiation therapy. We also pay attention to long-term side effects. These are longer-term issues that can emerge potentially months or years after radiation. So some of those urinary symptoms that initially recover can potentially get worse again later on with things like strictures or contractures in the urinary tract. We can also occasionally see rectal symptoms like discomfort or bleeding, though that thankfully is very rare. And in a few slides, I'll talk about some of the things we do to minimize those sorts of gastrointestinal side effects. We do also see a risk of erectile dysfunction, though that often does not emerge until years after a course of radiation. So while this is a very highly effective form of radiation, one of the downsides is that it's time intensive. It's daily treatment over about 6 weeks, and you have to come in every day. At UVA, we also offer another form of radiation that's called SBRT, which stands for Stereotactic Body Radiation. The overall idea of SBRT radiation is similar to what we're doing with IMRT radiation. However, we do it much faster. Instead of doing 28 low doses of radiation, we would do 5 doses of radiation, and we would space them out over about 2 weeks. We wouldn't usually do this regimen on back-to-back days. With this regimen, we generally would treat just the prostate. For higher risk individuals who need pelvic lymph node irradiation, we usually use the slower IMRT regimen. And the side effects and tolerance of this regimen are generally very similar to the IMRT side effects and sort of day-to-day tolerance and recovery from the radiation. There are some subtle differences that your doctor might go over with you, but they are overall pretty similar. One of the things we're especially excited about at UVA is that for this specific SBRT regimen, we have a specialized treatment machine that allows us to do live MRI guidance. So this is the specialized treatment machine we have here. It's called the Meridian ViewRay. And what it does is it takes a machine that can deliver standard SBRT or stereotactic radiation, and it incorporates live MRI targeting. So this is, I think something of a game changer in prostate SBRT because it gives us added precision. It gives us the ability to do live adaptations of our plan. So if anything shifts in your anatomy day to day because of changes in rectal positioning or bladder positioning, we can adjust that plan live while you're on the treatment table. And because we have this added precision, we can reduce the amount of treatment margins. So what that means is when we target a prostate with radiation, we always treat a small safety margin surrounding it. The idea there is that things can move while we're delivering the radiation beams, and we don't want to risk missing. And in many cases, that's typically about a 5 millimeter margin around the prostate. While that might seem small, that margin is right in the areas where we see side effects, particularly the bladder and the rectum. When we have live MRI guidance, we can shrink that margin by about half while still having very high confidence that we're hitting the whole prostate and not risking, a miss of our target. So this has been a great addition to our repertoire of treatment options at UVA. There was a clinical trial published called the Mirage trial that showed substantially reduced urinary, bowel, and sexual side effects when we use this MRI guidance compared to CT guidance. So it can be a great tool for some of our patients, but with the caveat that it is a little slower. You have to be in the very tight confines of an MRI for up to an hour with each treatment. And it doesn't really cover, this regimen doesn't really cover the lymph nodes. So it's best for lower or more favorable intermediate risk prostate cancers. So the procedure or a feature of our treatment when we use either an IMRT or SBRT treatment regimen is that we often will recommend a perirectal spacing procedure. So this diagram here, I think, shows one of our concerns with radiation. So on the left, we see a normal prostate here, and we can see that right behind it is the rectum. The red dotted line here, that represents a typical radiation field treating that sort of small safety margin, a few millimeters beyond the edge of our prostate. The overlap here with the rectum is why there is some risk of intestinal and rectal side effects with radiation. What we can do to minimize that risk is a procedure. It's about a 15-minute procedure where we put a needle in this space behind the prostate, and then we inject a hydrogel material. That material physically displaces the prostate and rectum away from each other. It creates just a little bit of space, about a centimeter, so there's not that much space, but it's just enough that we can still get this radiation field around the prostate while really minimizing the risk to the rectum and the side effects we see both short-term and long-term. So at UVA, we're pretty early adopters of this procedure, and we still do it for patients that are amenable to it. So in some individuals, if there was tumor in the area where the gel had to go, it might not be possible to do this procedure. But for many patients, it's a great option and can really help reduce radiation-related side effects. The last form of radiation that I'm going to talk about is called brachytherapy. This is very different from both IMRT and SBRT radiation. Those first two types of radiation, IMRT and SBRT, are external beams that are delivered from the outside in while a patient is lying down on a treatment table. Brachytherapy, in contrast, is a needle-based implant where radiation is implanted into the prostate and delivers dose from the inside out. So this is an invasive procedure, so it's done under anesthesia. And there's two forms of it. The original form was called a seed implant, also known as a LDR, or low dose rate brachytherapy implant, or a more modern version, which we do more of now, which is called a high dose rate implant, where you do a temporary implant into the prostate. The idea is that these hollow catheters are advanced into the prostate, all throughout the prostate gland. And then once everything is in place and we've mapped it out, we have a radiation source that can dwell at each position in the prostate and give off a dose of radiation from the inside out. So brachytherapy techniques are not quite as common as the IMRT or SBRT techniques that I talked about first, but they can be very useful. There's some advantages to it, so it's faster. Treatment with brachytherapy would usually be 1 or 2 treatments total. For higher grade tumors, particularly the Gleason 8, 9, and 10 tumors, it can be combined with a course of IMRT radiation as a way to escalate the intensity of the radiation and to reduce the risk of recurrence. Though I will be direct that brachytherapy also has some disadvantages as well. It's more invasive, requires anesthesia, and it has slightly higher risk of urinary side effects. So not all patients will be able to have this treatment, and even some patients who can have it might not want it because of those risks. But I think it's important to always go over each treatment option with each individual to make sure we can find the best fit. And for the right individuals, brachytherapy can still be an excellent treatment option. The last topic I'm going to go through is androgen deprivation therapy. So androgen deprivation therapy has a few names. It's also called ADT, or hormones, or hormone therapy. The idea here is that this is testosterone blocking medications. So the reason we do this is that the male body makes testosterone as a growth factor. It typically helps with things like muscle growth and libido and metabolism. That's its normal role. Unfortunately, prostate cancer cells are excellent at taking testosterone and using it to promote cancer growth. And if not treated, eventually cancer spread. I like to think of it as prostate cancer cells are almost addicted to your body's natural testosterone. What we can do is give you hormone-based medications, ADT, that basically block your body from making testosterone. That kind of starves and weakens the cancer cells, reducing the tumor volume, making the tumor potentially more sensitive to radiation. And if there was any undetected microscopic areas of disease that we couldn't see, it would potentially help treat those areas as well. So we don't always use androgen deprivation. There's a couple of different types we can use. Short-term or short course androgen deprivation is when we do it for 4 to 6 months. For certain intermediate risk prostate cancers, that's a great option, and it helps improve outcomes. For more aggressive high-risk prostate cancers, we would often do 1.5 to 3 years of androgen deprivation. That's called long-term hormone therapy. For high-risk cancers, that has been shown to improve the effectiveness of radiation and improve long-term outcomes. So these often go hand in hand with radiation therapy. For more advanced metastatic prostate cancers, sometimes our colleagues in medical oncology would do indefinite or permanent hormone therapy. So this treatment also has its own set of side effects. It's usually well tolerated. But we do see some fatigue, some hot flashes, some weight gain, and loss of libido as common hormone-based side effects of androgen deprivation. We're always careful with our patients to go over these beforehand and make sure that if we're doing hormone therapy, we're doing the correct duration to sort of match the intensity of our therapy to the risk of the cancer. There are some changes that have happened with androgen deprivation in the last 5 years or so, with some newer hormone-based treatments with medications like relugolix, or hormone-based intensification agents like abiraterone or enzalutamide. So we have lots of different options with androgen deprivation therapy. And if you did need one, we could help fund the correct one for that individual. So that really covers the components of my talk here. Thank you for listening. And I will turn things over to the other speakers in this education series. Thank you.
Hi, I'm Kirsten Greene. I'm the Chair of Urology at the University of Virginia, and I'm going to speak about some treatment options for prostate cancer. You just heard from Dr. Luminais, who covered radiation and androgen deprivation, so I'm going to touch upon surgery, active surveillance, and focal therapy. First thing to know about prostate cancer treatment is that there are many treatment options for prostate cancer. Active surveillance is an important consideration that is not a treatment option, however. Men who are diagnosed with low-risk prostate cancer should undergo active surveillance because they don't benefit from treatment. In other words, some men are diagnosed with prostate cancer so early and so non-aggressively that they don't actually need treatment, perhaps for 10 years, 15 years, or maybe for their entire lifetime. Now, some men who are diagnosed with prostate cancer do have progression, and that is why we do active surveillance, not watchful waiting. What this means is we're trying to avoid or delay the impact of treatment, the impact on you as a human being, on your function, the cost of treatment, but we don't want to compromise your ability to be completely cured of the cancer if and when the time comes. It's based on the rationale that the initial assessment is accurate, meaning we found what is actually there, and that our monitoring is able to accurately identify any type of progression in time that still allows for the cancer to be completely cured and for you to still have the same options as you do at the time that you're originally diagnosed. Active surveillance is about timing of treatment. It doesn't mean that you'll never need treatment, but it means that we're going to follow it closely and determine when you need treatment. It also gives you the opportunity to delay the side effects of radiation or surgery, which I'll go over in a bit, as long as possible to enjoy your quality of life without sacrificing any length of life. Critically, this is not watchful waiting. Watchful waiting means that you are never going to treat your prostate cancer, you're not going to be invasive, you're not really going to check on it with biopsies or imaging. Watchful waiting is just checking a PSA and letting the cancer take its course. Active surveillance is different. It's a commitment. It means you have to get your PSA drawn every 6 months, an MRI every 1 to 2 years, and a confirmatory biopsy a year after the original so that we know what is actually going on in the prostate in terms of cancer progression. And then follow-up biopsies happen every 2 to 4 years. Watchful waiting is completely different. And at some point, people want to transfer over to watchful waiting, maybe when they're older, if their cancer hasn't progressed in a really long time. When you choose watchful waiting, you are choosing never to cure the cancer, never to be invasive about it. You might get a PSA once a year just to see what it's doing, and you accept that the cancer might eventually spread, and that treatment is going to be controlling the symptoms of the cancer that's already spread, not curing the cancer. I think as a patient, it's really important to know, are you on active surveillance with close monitoring with the goal of treatment for cure at some point, or are you on watchful waiting? In terms of treatment, quality of life is critical. And the reason why we don't just treat everyone right away, why some people choose active surveillance if they're appropriate, is because both surgery and radiation have important impacts on urinary function. Surgery causes urinary incontinence, which is leakage. It causes erectile dysfunction. The penis gets shorter. It causes infertility because the ejaculate no longer can get out, and can do you can certainly do radiation as a backup or a salvage treatment, but that has some side effects as well. Dr. Luminais went over those. They're different from surgery. So instead of incontinence, you have more frequent, more urgent urination. You have some bowel irritation. Now, that doesn't happen with surgery. Erectile dysfunction happens gradually. With surgery, it happens right away and then gradually improves. You develop infertility over time as the prostate scars and the ejaculate can no longer get out. In terms of salvage or backup plan, that's different too. So if you do radiation, we rarely take out prostates as a salvage prostatectomy anymore. So if you do radiation as your first choice, surgery is not usually your backup plan. It's usually androgen deprivation therapy, focal therapy, or more radiation. In terms of active surveillance, it's important to remember this is a commitment. You have to follow up. PSA is not enough, and it's a long-term relationship between you and your urologist. So radical prostatectomy is not a TURP. That's the other thing. A lot of people come in and say, I want the laser treatment. Well, the laser treatment is a transurethral resection of a prostate where my colleagues go in and they laser out the center of the prostate. And that's just done for bladder neck obstruction, bladder outlet obstruction from a big prostate. A radical prostatectomy takes the entire prostate out, as well as the seminal vesicles and part of the vas deferens. They're two totally different surgeries. This is just a video kind of going through a common anterior approach. The prostate's actually in here under my hand, and you see there's a little layer of fat over top of the prostate. And essentially the goal of the surgery is to cut in there, find the catheter, get the nerve bundles off the side, leave all the healthy tissue behind that we need to leave behind, and take out the prostate. And so this is an anterior approach. There's also a posterior approach to prostatectomy called Retzius sparing, but essentially you can see the prostate is on the left side of the screen here. All the nerves and all the covering is being taken off of it. And then the urethra is going to be right under all of this tissue. This bleeding area is called the dorsal vein. And that's controlled usually with stitches or with a stapler. Now, this is a different way to do a prostatectomy called Retzius sparing. This leaves the prostate up in the air here. The rectum is down below and essentially gets the prostate out, same as the other way, but just from a slightly smaller hole. You can see the side of the prostate there. Retzius sparing prostatectomy tends to have a little bit faster urinary continence rates than the anterior approach. That's the bladder up top. That's the bladder neck coming through. You see the catheter and the prostate's down here. So this is the prostate being removed. So two different ways to do exactly the same objective of removing the prostate. Different ways to approach the problem. None of them have lasers. In terms of radical prostatectomy side effects, erectile dysfunction is guaranteed. Everyone has it, and it recovers over a time period of about 3 years. It'll never be better than your baseline function. Urinary incontinence comes back more quickly. That recovers over 1 year, and it's important for patients to do pelvic floor physical therapy to hasten that recovery and to do Kegel exercises. Penile shortening is variable. It depends on the size of the prostate. If a lymph node dissection is performed, some patients develop lymphedema, which is leg swelling, or lymphocele, which is a fluid pocket that can develop. Both surgery and radiation are equally good ways to cure prostate cancer. This is the bladder, this is the prostate and urethra. With the radical prostatectomy, the nerve bundles that control erection are on the back of the prostate and run up the sides. We try to save these nerve bundles during surgery. With radiation, they stay in place. They're not removed or cut, but the radiation damage will eventually scar down some of the little vessels and cause trouble years in the future. With surgery, it's more of a true mechanical disruption of these nerves. One important thing I like to remind patients is that surgery is not a guarantee. Sometimes people say, well, I just want surgery because it's a guarantee to get it all. And that's not true. Little prostate cancer cells can be left behind, and we can't see prostate cancer during the surgery. So after surgery, the definition of recurrence is if your PSA ever reaches 0.2, two different measurements in a row. Anything below that value, you're considered cancer-free. After radiation, it's when the PSA rises 2 full points above whatever the lowest value is. So in terms of recovery, you're going to hear more about this in the coming weeks. There's sexual function recovery, urinary function recovery, and then I want to say a few words about fertility and testosterone, because I often get these questions about treatment. Even before that, though, in terms of sexual function recovery, the most common thing that we start off with are oral pills. These are called PD-5 inhibitors, things like Viagra, Levitra, Cialis. These are the most common way to start, and they're contraindicated if you use any nitrates. However, this will be the first-line treatment for erectile dysfunction. Urinary continence recovery has to do with the fact that men have two sphincters, as indicated by A and B. When we take the prostate out, sphincter A is removed, leaving you only with one sphincter. So you have to develop the muscle tone in that one sphincter and essentially retrain your body to control your urine with just the one muscle instead of two. It's really important to do pelvic floor physical therapy to rehabilitate this. This just shows the cut that's made at the sphincter. And that recovery is a critical part. We set you up with pelvic floor physical therapy to help. Now, a few final words about focal therapy. This is a very important option for some patients. This can be heat, it can be cold. Cold is called cryo. HIFU is high intensity focused ultrasound. That's ultrasound waves that heat or cook. And there's something called IRE, which is electrical current. The idea being that you could potentially ablate either with heat or cold or electricity half of the prostate or just a little spot in the prostate that has the worst cancer. Now, with focal therapy, this is not treating the whole prostate like prostatectomy or radiation does. It just treats a spot. So it kind of puts you back on that active surveillance pathway to monitor closely and make sure that the cancer doesn't develop in other locations or come back. What's great about focal therapy is those nerve bundles stay intact, and so do the sphincters, and they're not damaged over time. So it's a balance between cancer cure and quality of life. UVA is going to be offering HIFU treatment very soon. Going back to urinary continence, Kegel exercises after prostatectomy, pelvic floor physical therapy, these things are critical. Often patients don't need this after focal therapy, but this is the mainstay after prostatectomy. Now back to fertility. Once the prostate is removed, men are infertile simply because the ejaculate that carries the sperm cannot get out. After radiation, men are temporarily fertile, but over time, the ejaculate declines. If you are interested in preserving your fertility and you want to have a radical prostatectomy, it's critical to sperm bank prior to surgery. And testosterone. This is a hot topic. I think it's important for men to know that testosterone is a part of the prostate cancer pathway. It does make prostate cancer grow, but it's safe to have testosterone in a normal range after curative therapy. It's really controversial when you're on active surveillance. Should testosterone be replaced? How high is safe? The prostate cancer gland itself does not make testosterone, which a lot of people are concerned about after surgery. Is their testosterone going to go down? The answer is no. The prostate doesn't make testosterone, but it's very sensitive to testosterone, which is why androgen deprivation therapy, as Dr. Luminais discussed, impacts the prostate size as well as prostate cancer. Androgen deprivation therapy is not curative. It is used with radiation. It is not used with surgery. There's so much more to talk about, and you have lots and lots of more interesting talks ahead in the month in terms of recovery and the journey to getting completely back to normal after your curative treatment. These are some resources about prostate cancer early detection, localized treatment, advanced treatment, and a reminder, UVA has a prostate cancer support group every month. This is the email to join the support group. You're all welcome to come, and thank you so much for your attention.